Dr. Hiraoka, could you please tell us about thermal therapy for hepatic cancer? In particular, how do you measure the temperature? Well, first, while viewing an echography analyzer, we insert a 19 or 21 gauge elaster needle into the tumor. Then we set a heat-conductive thermometer into the closed-in catheter to measure the temperature of the tumor site. Immediately after the heating time has elapsed, the thermometer is withdrawn at 1 centimeter intervals to measure the temperature distribution in the tumor and peripheral tissue. What is the target temperature, and how long is the heating time? The heating time is 45 to 60 minutes, and the target temperature is above 42 degrees Celsius. What special techniques do you use when the temperature cannot be easily elevated? The main problems associated with RF heating are the heating of subcutaneous fat and the occurrence of pain due to the edge effects. For a patient with thick subcutaneous fat, either sufficient pre-cooling or extra abdominal heating while the patient is in a prone position or heating by sandwiching the tumor with electrodes may be effective. To overcome the edge effects, we make sure to use an overlay bolus. If pain cannot be eliminated through these methods, we use a gauze soaked with physiological saline solution or electroconductive jelly. What kinds of combination therapies are used? And please tell us about the intervals with thermal therapy and the sequence of the therapies. We use various combination therapies, including coronary artery embolization therapy, radiotherapy, and chemotherapy. The first choice for combination therapy is coronary artery embolization therapy. Generally, a gelatin sponge is used, and adriamycin or mitomycin C is injected. Several days after the arterial therapy, thermal therapy is performed twice a week for a total of 8 applications. Patients treated with combination radiotherapy are those for whom coronary artery embolization therapy is not performed, those who do not suffer severe ventilation disorder, and those in whom the lesions are localized. In these cases, a careful treatment schedule should be devised to keep the radiation exposure field as narrow as possible. Radiotherapy is performed 5 times a week, with 1.8 to 2 gray dose of radiation exposure, for a total of 50 to 60 gray of radiation. Thermal therapy is performed twice a week after radiotherapy. Chemotherapy is used in combination with thermal therapy for patients on whom coronary artery embolization therapy or radiotherapy has not been performed. Generally, we use a retention subcutaneous reservoir retained in the coronary artery to inject adriamycin or ipratropium once a week before beginning thermal therapy. Could you tell us about the results of these treatments? Yes, I can show you the treatment results for 45 patients who received more than 6 cycles of thermal therapy and in whom the tumor temperature could be properly measured. Complete regression of the tumor was noted in 18% of these patients, and a total of 42% of patients showed positive effects from the treatment. This included 24% who showed partial regression, with more than 50% reduction of the tumor. Results in cumulative survival rates were calculated by stochastic programming. The 1-year survival rate was 49.7%. The 2-year survival rate was 33.1%. Could you give us some symptomatic examples? Here is a case in which a tumor on the right lobe of the liver measured 12 by 8 centimeters upon completion of treatment. Because a serious ventilation liver function problem was noted, with the tumor embolization reaching to the main portal vein, thermal therapy was performed together with 5-FU and OK-432. Thermal therapy was repeated 8 times. As a result, the tumor completely disappeared and the AFP value decreased to the normal range from 425,000. This patient is now doing very well 10 years following the treatment. Thank you very much, Doctor.